Patients here.
Oh boy, got some blood going.
Yeah, this is never blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application
for 45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the Deep Dive. We are shifting gears today. Usually we take a pretty broad look at a topic, history, tech, culture. But today, I feel like I've been handed a clipboard and a stethoscope.
You basically have, yeah.
Yeah.
Today isn't just about learning something. It's really about learning how to think like a clinician.
Yeah.
We are diving into the very high-stakes world of pediatric nursing.
I have to admit, when I saw the stack of research you sent over, textbooks, CDC protocols, vaccine inserts, I felt a little overwhelmed. It's dense stuff.
It is.
Who is this actually for? Is this just for, the nursing students sweating over their boards, or should the rest of us stick around?
Oh, it's for the students, absolutely. But it's also for parents. It's for the person who wants to understand why their doctor says no to antibiotics for a cold.
Okay.
It's for anyone who really wants to get the mechanics of how a virus can hijack the human body. Because the disease we're covering today, mumps, is practically the prototype for these kinds of viral infections.
Mumps, the chipmunk disease.
Exactly. It sounds quaint, doesn't it? Almost retro. But it is a perfect case study. It has these really distinct stages, it has specific targets in the body, and it has some genuinely terrifying safety traps that, if you miss them, can lead to tragedy.
That is where I want to start. You mentioned a mission for this deep dive. We aren't just reading the textbook. We are doing something you called the Pareto 80-20 review.
Right. And this is a concept that saves lives. And honestly, it saves exam scores. The Pareto principle, it says that 80% of your results come from 20% of your efforts.
Okay, the 80-20 rule.
Exactly. In medicine, that means we cannot memorize every single line of the textbook. It's impossible. If you try to memorize, the molecular weight of the mumps virus, you are just wasting brain space.
That's the nice-to-know stuff.
Correct. We are hunting for the need to know. That's the 20% of information that answers 80% of the exam questions and, critically, prevents 80% of the bad outcomes at the bedside. We're looking for the red flags and the safety stops.
I love that. I'll be the learner here. I'm going to ask the dumb questions so the listener doesn't have to. I want to understand the why behind these rules, not just, memorizing the rules themselves.
That is the best way to learn.
Yeah.
It really is. If you understand the why, you don't have to just memorize the what.
So let's look at the map. We're calling this Section A, the Master 80-20 map. When you look at mumps through this 80-20 lens, what are we actually looking at? It's not just swollen cheeks, is it?
No. Not at all. Mumps is the prototype for what we call the viral, glandular, and respiratory pattern. That is your first mental hook.
Glandular and respiratory?
Yes. It enters through the breathing tubes, it hits the blood, and then it goes hunting for glands.
It's a hunter.
It is. And on our map, there are 4 massive landmarks. These are the things that if you were a nurse, a parent, whatever, you cannot miss them.
Okay, lay them out for me. What is landmark number 1?
Landmark 1 is the isolation window. This is pure public health. You have to know exactly when that child is, radioactive, so to speak. If you get this wrong, you send a contagious kid back to school, and suddenly you don't have one case, you have an outbreak.
Okay, so timing is everything. What's number 2?
Number 2 is the can't-miss safety item. For mumps, and really for any viral thing in kids, it is the aspirin trap.
I've heard this, don't give kids aspirin, but I've never really understood why. It's just a painkiller, right?
We are going to go deep on that because the mechanism is, it's frightening. It involves the liver and the brain basically shutting down. It's called Reye syndrome.
Okay, you have my attention. That sounds incredibly high stakes. What is landmark number 3?
Number 3 is the anatomy of complications.
Yeah.
This is where we move beyond the chipmunk cheeks.
Yeah.
You need to know the virus has a specific set of keys, and it's looking for specific locks in the body. It unlocks the testes, the ovaries, the pancreas, and the lining of the brain.
So it's a systemic invader. It goes everywhere.
It does. And finally, number 4 is vaccine contraindications. We have a live vaccine, the MMR. But because it is live, there are certain people who absolutely cannot handle it. Giving it to the wrong person is a catastrophic error.
So that's our roadmap. Isolation, aspirin safety, systemic targets, and vaccine rules. If we master those, we've got the 80%.
You've got it. That's the core.
All right, let's move into section B. This is the deep dive lecture. Let's start with a definition. If I'm walking into a patient's room and I just need a one-liner to ground me, what is it?
Okay, here is the clinically accurate one-liner. Mumps is an acute viral illness caused by a paramyxovirus. It primarily causes parotitis, that's the swelling of the salivary glands, but it has the potential for really serious systemic complications like orchitis and meningitis, and it is preventable via a live attenuated vaccine.
Okay, paramyxovirus, keratitis, systemic complications. Let's strip that down. Talk to me about the pathology in plain English. You mentioned it enters through the respiratory tract. Walk me through the journey of that virus.
Okay, so imagine you are the virus. You are floating in a microscopic droplet of saliva. Maybe someone sneezed, or, more likely, a kid shared a water bottle at soccer practice.
Gross, but yeah, standard kid behavior.
Extremely standard. So you enter the new host through the nose or mouth. You land in the nasopharynx, the back of the throat. This is your beachhead. You start replicating there in the local lymph nodes. You are building your army.
And does the kid feel sick yet at this point?
Not really, no. This is the incubation period. And it takes a while, usually 16 to 18 days on average.
16 to 18 days, that's a long time.
It is a very long time.
Wow, over 2 weeks. So the kid who sneezed on you is long gone from your memory.
Exactly. And that's why tracking it's so hard. So after you've built your army in the lymph nodes, you launch the invasion. You enter the bloodstream. This is called viremia.
Viremia, the virus is in the blood.
Right. Now you are on the superhighway.
And this is where the hunter thing comes in.
Yes. The virus is circulating. It's surfing the blood. But it doesn't just attack random tissues. It ignores the muscles. It ignores the bones. It is specifically looking for glandular tissue. It has a chemical affinity for it. It's like a lock and key mechanism.
So it finds the salivary glands first.
Right, the parotid glands. That's the classic #1 target. But it also finds the pancreas. It finds the testes in boys. It finds the ovaries in girls. And, frighteningly, it can cross the blood-brain barrier and find the meninges. That's the lining of the brain.
It sounds incredibly precise for something that's just a microscopic germ.
Evolution is a master engineer. It's very, very specific.
Now, does this invasion look the same in everyone? If a toddler gets it versus a teenager, is it the same experience?
No, and this is a massive exam point. Age matters a lot. In young children, infants, toddlers, preschoolers, mumps is often what we call subclinical, or just really mild. They might seem a little fussy, maybe a little fever. They bounce back quickly.
Okay, so it's not a huge deal for them.
Not usually. But once you hit puberty, the game completely changes. In adolescents and adults, the complications are much more frequent and much, much more severe. The virus just hits harder.
Why is that?
Well, it's partly the immune response being more robust and causing more inflammation, and partly the maturity of the tissues themselves. For example, orchitis, that inflammation of the testicles, it's extremely rare in a 5-year-old.
Right.
But in a post-pubertal male, it happens in up to 30% of unvaccinated cases.
1 in 3.
1 in 3. And that is a significant, painful, and psychologically distressing event.
We are definitely going to talk more about that because that sounds like an absolute nightmare for a teenage boy. But let's stick to the assessment for a second. I'm the nurse. A parent brings their child in. What am I actually seeing? What does parotitis look like in real life?
You are looking at the jawline. The parotid gland sits right in front of the ear, and it sort of wraps around the angle of the jaw. When it swells, it just obliterates that sharp jawline definition. It pushes the earlobe upward and outward.
So they look puffy.
They look like they are storing nuts for winter, hence the chipmunk nickname. It's very accurate, but before you even see the swelling, there's a telltale sign. The child will often complain of an earache.
An earache, so you'd think it was an ear infection.
Exactly. And that's a common misdiagnosis at first because the gland is swelling and it's pushing against all the structures of the ear canal. So you look in the ear with your otoscope and the eardrum looks perfect. It's pearly gray, no infection. But the kid is screaming in pain.
That's the clue. It's not the ear, it's the pressure on the ear.
Precisely. And if you palpate, gently touch the angle of the jaw, they will jump off the table. Chewing hurts. Talking hurts. Anything that stimulates saliva hurts. There's actually an old school trick called the pickle test.
The pickle test? You're kidding.
Not at all. You give the kid something sour, like a pickle or a drop of lemon juice. Sour foods stimulate a massive rush of saliva from the gland. If the gland is inflamed and the duct is blocked, that rush of fluid causes intense, sharp pain.
That sounds incredibly mean.
We don't really do it anymore because it's cruel, but it illustrates the physiology perfectly. The gland is blocked and angry.
Okay, so I've got a kid with a puffy jaw, ear pain, and he hates pickles. I'm worried about complications now. You mentioned the brain. What am I checking for there?
You are doing a neurological assessment. You are checking for neutral rigidity.
Fancy word.
It just means a stiff neck.
Mm-hmm.
You ask them, can you touch your chin to your chest? If they can't, or if trying causes a shooting pain, that suggests the meninges are inflamed.
Okay.
Then you check for a severe headache, and for photophobia, that's sensitivity to light. Are they squinting in a normally lit room? Those are the red flags for meningitis.
Okay. And now, let's talk about the boys. You said 30% of postpubertal males get orchitis. How do we assess that without, completely traumatizing the poor kid?
This requires high emotional intelligence. It really does.
Yeah.
You are dealing with an adolescent male. He is already self-conscious about everything. Now his testicle is swelling to potentially double its size. And it is excruciatingly painful.
Double the size?
Yes. It can be very dramatic. And with that comes a huge fear. The fear of sterility.
Well, is that a valid fear? I mean, if your testicle doubles in size and gets that inflamed, I would assume it's being destroyed.
This is probably the biggest exam writer favorite and counseling trap in the entire topic. Listen closely. About 50% of the time, orchitis leads to testicular atrophy.
Atrophy means shrinking.
Yes. After the swelling goes down, the testicle will shrink and lose some of its mass. However, and you need to underline this mentally, sterility is actually rare.
Wait, really? How can both of those be true?
Yes. Because even if the affected testicle shrinks, it usually retains enough hormonal function and sperm production to be functional. Or, more commonly the other, unaffected testicle completely compensates. Total sterility from mumps orchitis is a very, very rare outcome.
That is a massive distinction.
It is everything. Imagine you are the nurse. You have a terrified 17-year-old and his terrified father in a room. If you imply that he's going to be infertile, you are causing serious psychological damage that just isn't supported by the evidence.
So what's the right way to say it?
You have to explain it clearly. You say,
Right.
I know this is scary and very painful. The swelling will go down. It is possible that it might get smaller afterwards, but you will very likely still be able to have children in the future.
That is the need to know right there. Atrophy does not equal sterility.
Precisely. Write it in stone.
Okay, let's talk about interventions. We know what it is. What do we do? Do we give antibiotics?
Absolutely not. And if you see an exam question listing amoxicillin as an option, run away from it. It is a virus. Antibiotics do nothing but kill the good bacteria in your gut.
So we are helpless?
No, we are supportive. We treat the symptoms. We manage the pain and the fever. And this brings us to the biggest safety trap of the entire deep dive, the aspirin trap.
Yes, you warned us about this. Why can't I give a 10-year-old with a fever some aspirin? It works for me.
Because you are an adult. Your liver works differently. In children and teenagers, if you introduce aspirin, the chemical name is salicylates, during a viral infection like influenza, chickenpox, or mumps, you can trigger a metabolic disaster called Ray syndrome.
Break down the mechanism for me. What actually happens?
The aspirin, combined with the stress from the virus, damages the mitochondria inside the liver cells. The mitochondria are the little power plants of the cell. When they fail, the liver stops doing its job. It stops processing toxins.
Okay, that sounds really bad.
It gets much worse. A toxin called ammonia begins to build up in the blood because the liver isn't filtering it out. That ammonia travels to the brain, and it causes cerebral edema, brain swelling.
So you go from a common fever to brain swelling.
Rapidly. The child will start vomiting uncontrollably, become confused, then aggressive, then lethargic, and then they can slip into a coma. It has a very high mortality rate.
That is absolutely terrifying.
It is, and that is why we have a hard and fast rule in pediatrics. No aspirin. Use acetaminophen, which is Tylenol, or ibuprofen, which is Motrin. Never aspirin. And you have to watch out for things like Pepto-Bismol, because that contains salicylates too.
Pepto-Bismol? I would not have even thought of that.
That's a classic hidden trap. A parent trying to treat an upset stomach accidentally causes a huge problem.
Okay, so supportive care, pain meds, but not aspirin. Hydration, what about ice packs for the jaw?
Or warm packs. Honestly, whatever feels better for the child. There is no hard rule there. It's about comfort.
Now let's go back to landmark number 1, isolation. The kid is sick. Can they go to school?
Absolutely not. This is a strict public health rule. A person with mumps is contagious from about 2 days before the swelling starts until 5 days after the swelling starts.
But we don't know they are sick 2 days before.
Right. And that's the tricky part. That's why outbreaks spread so easily. But once you identify the swelling, the parotitis, the clog starts. You must isolate them for 5 days from the onset of that swelling.
Why 5 days? Why not 7 or 10?
Because the viral load in the saliva drops off precipitously after day 5. The risk of transmission becomes negligible at that point. So 5 days is the scientifically determined balance point between public safety and getting the kid back to their life.
Got it. 5 days. Write that down.
And droplet precautions. If you are the nurse in the hospital, you wear a mask. The virus travels in spit and sneezes.
Let's pivot to Section B, Part 5. Development. We always talk about how these diseases impact development. How does mumps mess with a child's milestones?
Well, let's start with the toddler. We mentioned hearing loss as a complication.
Right, from the meningitis or encephalitis.
Exactly. The mumps virus can directly damage the hair cells in the cochlea of the inner ear. It can cause permanent unilateral, that means one-sided deafness.
That's huge for a toddler who is just learning to speak.
It is a massive deal. If you have a 2-year-old who recovers from mumps and suddenly they start responding when you call them from the other room, or their speech starts to slur or even regress, that is a massive red flag. You need a hearing screen immediately.
And for the adolescent, what's the developmental impact there?
It's social and emotional. First, missing 5+ days of school is stressful for a teenager. But the body image issues associated with orchitis are profound. Developmentally, teenagers are in Erickson's stage of identity versus role confusion.
They just want to fit in.
They want to fit in more than anything.
Yeah.
Having a medical condition that affects their genitals makes them feel other or broken at a time when they are most vulnerable.
So the nurse isn't just treating the swelling, they are treating the teenage ego.
You absolutely are. Privacy is paramount. You do not discuss his testicular swelling in the hallway where his classmates might hear. You create a safe space for him to ask embarrassing questions.
Good advice. Let's move to Section C, the vaccine. This is our main weapon against mumps, the MMR.
Measles, mumps, rubella.
And there's a version with chickenpox too, right?
Ah.
MMRV.
Yes. And this is a really important nuance that pediatric nurses need to know. We have 2 ways to give these shots to a baby at their 1-year checkup. We can give MMR and varicella as 2 separate pokes, or we can combine them into 1 shot, the MMRV.
1 shot sounds better. Less crying, right?
You would think so, and parents often prefer it. But the data shows something very interesting in toddlers, specifically in that 12 to 23-month age group. The combined MMRV shot has a slightly higher risk of febrile seizures.
Seizures caused by fever.
Yes. The immune response is so robust to the 4 viruses at once that the fever can spike higher and faster than with separate shots, and that can trigger a simple febrile seizure in susceptible toddlers. The risk is about 1 in 2,300 kids.
That's small, but it's not 0.
Correct. So the official recommendation from the CDC is this. For the first dose, the 1-year-old dose, it's preferable to give them separately. MMR in one leg, varicella in the other. It lowers that fever risk.
And for the older kid, the 4-year-old getting their kindergarten shots?
By age 4, the risk of febrile seizures drops to almost 0. So for the second dose, you can absolutely use the MMRV combo. Save them a poke.
That is such a specific, high-yield detail. Separate for baby, combo for pre-K.
Exactly the kind of thing they'd ask on an exam.
Now, contraindications. Who absolutely cannot get this vaccine?
Remember, it is a live attenuated virus. That's key. It means the virus in the shot is alive, just significantly weakened. It has to replicate a little bit in your body to teach your immune system what to do.
So if your immune system is, well, garbage.
The vaccine can actually make you sick. The weakened virus can become a real infection. So severe immunocompromise is a hard stop. We are talking about chemotherapy patients, children with advanced HIV who have very low CD4 counts, or kids on high-dose steroids for a long time.
How about pregnancy?
Pregnancy is an absolute contraindication. Theoretically, the rubella component could harm the developing fetus. So we tell women to avoid getting pregnant for at least 4 weeks after they get the vaccine.
And if they are already pregnant and need the vaccine?
They have to wait until after they deliver to get vaccinated. No exceptions.
Okay. I have to ask about the controversy. We can't talk about MMR without talking about autism.
No, we have to address it. Every nurse, every provider will face this question from a parent. And you need to have a script ready that is compassionate but firm on the science.
What is that script?
The script is something like, I understand you are trying to protect your child. That is my goal too. I can tell you that this question has been studied more than almost any other medical question in history. Millions of children across multiple countries have been tracked. The National Academy of Medicine, the CDC, the World Health Organization, they have all concluded there is no link between the MMR vaccine and autism. The original study from the 90s that suggested a link was found to be fraudulent, and the doctor lost his license.
Clear, definitive, but respectful.
You have to be. Shaming a parent never changes their mind. But you cannot waver on the science. The science is settled.
One more specific trap regarding the vaccine. Blood products.
Ah, yes. This is the antibody interference rule. It's a bit tricky. If a child has received a blood transfusion, or IVG, that's intravenous immunoglobulin recently, their blood is full of someone else's antibodies.
Okay, so they have passive immunity.
Exactly. And if you give a live vaccine, while those donor antibodies are still floating around, those antibodies will attack the vaccine virus and kill it before the child's own immune system can learn from it.
It effectively neutralizes the vaccine.
It completely neutralizes it. So the vaccine won't work. You have to wait. Sometimes it's 3 months. Sometimes it's up to 11 months, depending on what blood product they got and at what dose.
That is a great deeper level check. Have you had a blood transfusion lately before giving the shot?
It's a standard screening question on the vaccine forms for that exact reason.
Okay, Section D, cross-linking. We are in the differential diagnosis phase. A kid comes in with a swollen jaw. Is it always mumps?
No, definitely not. And this is where good clinical detective work comes in. Parotitis, the swelling, can be caused by a bunch of other things.
Like what?
Epstein-Barr virus, which causes mono, can do it. Influenza A can do it. Even HIV, in some cases, can present with parotid swelling.
What about non-viral things?
Absolutely. You can have silithiasis.
What?
Silithiasis, it's a salivary duct stone, just like a kidney stone, but it forms in the saliva duct. It blocks the flow of saliva, and the gland swells up behind the blockage.
How do you tell the difference between a stone and mumps?
A stone is usually unilateral, so just one side, and the pain and swelling often get much worse right when they start eating, because that's when the gland is trying to secrete saliva. Mumps is viral, so you usually have that fever and body ache prodrome. Also, mumps is epidemic. If 5 kids in the same 3rd grade class have swollen cheeks, it's not stones.
That's mumps. Right.
Another interesting differential, especially in adolescence, is bulimia nervosa.
Really? An eating disorder. How does that cause it?
Yes. The chronic vomiting forces stomach acid into the mouth, which constantly irritates the parotid glands. Over time, you can get bilateral parotid hypertrophy, that's swelling in patients with bulimia. So if you see a teenage girl with puffy cheeks but no fever, and you notice worn-down tooth enamel from the acid.
You need to be thinking about bulimia, not mumps. Wow, that is a crucial need to know.
It is, because it changes the entire care plan. You're not looking for a virus, you're looking at a serious mental health condition.
Let's talk about breakthrough cases. We hear about these outbreaks on college campuses all the time. Mumps outbreak at State University, and almost all the kids are vaccinated. Does that mean the vaccine is trash?
No, but it does mean the vaccine isn't a magical force field. The MMR is about 88% effective against mumps after 2 doses. That is very good, but it's not 100%.
So 12 out of every 100 people are still vulnerable.
Roughly. And we also know that immunity can wane over time. So if you got your last shot at age 5, by the time you're 20, your antibody levels might be lower. Combine that with a college dorm. Kids living on top of each other, sharing drinks, stressed out, not sleeping, and the dose of viral exposure can be high enough to overwhelm that waning immunity.
But, and this is the key question, if a vaccinated kid gets it, is it the same disease?
No. And this is the most important takeaway for parents. Breakthrough cases are consistently and significantly milder. They have less fever, the swelling lasts for a shorter time, and most importantly, they have significantly lower rates of complications like orchitis and meningitis.
So the vaccine acts like a seatbelt. You might still get in a crash, you might get a dent, but you don't fly through the windshield.
That is the perfect analogy. It converts a potential catastrophe into a manageable nuisance.
This brings us to the final provocative thought for our outro. You mentioned it in your notes, the 3rd dose.
This is where the science is evolving in real time. Because of these college outbreaks, the CDC now recommends a 3rd dose of the MMR vaccine for people who are identified as being part of an outbreak group.
So if my dorm has a mumps case, I should go get a booster shot.
Exactly. It's a public health strategy to quickly boost those antibody levels back up to fight off the high level of viral exposure in that close contact setting. It acknowledges that immunology isn't one and done. It's dynamic.
I like that. It shows that medicine is always learning, always adapting.
Always. You have to be.
All right, let's do a rapid-fire recap. The elevator pitch for the mumps 80-20. Expert, take us home.
Okay, 5 points. 1, safety first, no aspirin, ever. Risk of Raynaud's syndrome, use Tylenol or Motrin.
Got it.
Isolation, 5 days after the swelling starts, not from the fever, from the swelling. Droplet precautions.
5 days. Okay.
3, assessment. Watch for a stiff neck. That's your meningitis red flag. And in postpubertal boys, assess for testicular pain, which is orchitis.
Neck and testes.
Yeah.
Check it.
4, counseling. On orchitis, remember, atrophy is common, but sterility is rare. You have to reassure the patient and the family with accurate information.
Huge.
And 5, vaccine. It's a live virus, so it's contraindicated in pregnancy and severe immunocompromise. And remember to recommend separate shots for babies to reduce the risk of febrile seizures.
You nailed it. I feel like I could pass the NCLEX right now. Well, maybe just the mumps section of it.
One section at a time. That's how you do it.
To our listeners, thank you for diving deep with us today. Whether you are scrubbing in for a shift or just trying to keep your family healthy, knowledge is the best PPE you have.
Keep your patients safe, check those ears, check those vaccine records, and we will see you next time.